Good morning, everyone. Good morning, everyone. Thank you all for coming. I always hate to suppress the spontaneous conversations, but we have an exciting program today that I'd like to get to. So thank you all for coming today. What we're doing today is trying to build on yesterday's momentum on that panel discussion we had yesterday at an extraordinary event. And we have an exceptional opportunity this morning to build on that with a roundtable discussion about the future of healthcare. And I am delighted to have everyone here this morning. I really want to express a lot of gratitude for a lot of different reasons. So first of all, let me just thank the Surgeons General who are with us today. And Dr. Adams, Dr. Benjamin, Dr. Elders, Dr. Moritsugu, and Dr. Novello. Thank you for joining us today again. Looking forward to the discussion. I also would like to thank...
I appreciate you going in alphabetical order. It's the only time I get mentioned before everyone else.
I'm glad you picked up on that. I did that on purpose. Dr. Theodore, thank you for being here to help moderate our discussion. Appreciate your participation. I want to take one moment to thank all of the staff that have been behind the scenes that have helped make all of this work in the past couple of days. Staff members from the Geisel Dice office, from the Dean's office, from our advancement office, from the Koop Institute. People have really come together and been inspired to help work together to pull this off. And so it's been a remarkable effort. So I would like to thank all of those people individually and in their support of this. So thank you. And events like this don't come off also without sponsorship from the organizations. So I want to thank, Geisel has helped sponsor this, Dartmouth Health, Dartmouth, the Koop Institute, and also Genentech is here and has helped sponsor this. So I would like to thank all the groups that have come together, and certainly Dr. McBride for helping us put this together. Yeah. This was something that she and I talked about when she first arrived, and Dr. Novello came into the conversation, and really it was a vision that she created to bring this together on our campus to highlight these important issues and to be able to bring the Surgeon General here on campus to spotlight these issues. It's incredible, and so Dr. McBride, thank you so much for doing that. I'm also really proud, this will become public very soon, but the Geisel has received the 2023 Health Professions Higher Education Excellence and Diversity Award from Insight and Diversity. You know, it's really a rare award, and I want to thank everyone in our community and our DICE office, Lisa's leadership, Erica's leadership to help us get this recognition. So it's a really exciting time. So thank you for that. And so I'm going to step aside, and I would like to call Dr. Bernstein to the podium to kick off the overall discussion. Dr. Bernstein is the Chief Research Officer of Dartmouth Health. He's a Senior Associate Dean for Clinical and Translational Research at Geisel, and also the Director of the Everett Koop Institute. Steve.
Thank you, Dean Compton. Good morning and welcome to all of you, especially our distinguished guests, all of you in the audience today, and everybody watching on the live stream as well. As director of the Everett Koop Institute here, it's my great pleasure and honor to welcome all of you to this wonderful event. Many of you know that Dr. Koop was the 13th Surgeon General of the United States, an alumnus of Dartmouth, a pioneer in the field of pediatric surgery, and a vigorous champion, both of public health as a field, as a specialty, and of the health of the American public. His leadership during the early years of the AIDS pandemic, his work on tobacco control, and his recognition of a woman's right to choose made him an iconic figure in American medicine and public health. Many of the Surgeons General here knew Dr. Koop, and many of them worked with him directly. Our panelists today, as the Dean said, included Dr. Antonia Novello, the 14th Surgeon General of the United States, Dr. Joycelyn Elders, our 15th Surgeon General, Dr. Kenneth Moritsugu, Acting Surgeon General in 2002 and again 2006 to 2007, Dr. Regina Benjamin, our 18th Surgeon General, Dr. Jerome Adams, 20th Surgeon General of the United States. We're honored as well today by the presence of Cora Koop in the audience. Cora, would you mind standing up? Most of us today, most of us in the audience who are practicing clinicians, practicing physicians or nurses, including myself, we treat patients one at a time. The men and the women on this stage were responsible for caring for an entire country, now over 300 million people. And they did it not in the privacy of an examination room, like we do, but on a national stage, answerable to a presidential administration with its own priorities, including at times political considerations that might affect the work of the Surgeon General. They touched on some of this yesterday at the event at the college, which I'm sure many of you heard. I look forward to hearing our guests discuss these and other issues today. Our topic, the future of healthcare, is deliberately open-ended. We did that on purpose. The Surgeons General are prepared for any and all of your questions. Please, especially those of you who are new in your career, students, residents, or early in your career trajectory, please take advantage of this extraordinary opportunity. Please ask your questions. And finally, I'm delighted also to introduce our moderator, Dr. Pierre Theodore. Dr. Theodore is Director of Health Equity and Patient Impact at Roche Genentech, the global pharmaceutical firm. He's a cardiothoracic surgeon and a clinical associate professor at Stanford. We share an alma mater, by the way. And he has extensive experience both in academic medicine and in the private sector. Please welcome our Surgeons General and Dr. Theodore. Enjoy the day. Thank you.
Thank you. Thank you so very much. And Dr. Bernstein, thank you for that very warm welcome. And I would like to add my particular thanks as well to Dean Brown and Dean McBride and to Dean Compton. Thank you so very much for the invitation to Genentech to join you. And Mrs. Koop, it's really a true honor to be in your presence as well. And we're delighted to celebrate this discussion with some of the most senior leaders globally in public health, largely in the shadow of your widow. So thank you very much for joining us. Many of you may have had the opportunity yesterday to join the conversation with Dr. Gupta, and I was actually struck by the fact that that conversation started around the uniform that the Surgeons Generals wear. And I thought that was an interesting way to start a conversation, because surely there is a heft and there is an importance related to the uniform itself. It creates the bully pulpit from which policy can be advanced that very much shapes the public health agenda for the United States. Indeed, a critical issue is the strength of the office. But I will say, having had the opportunity to interact with each of the Surgeons Generals, that the human being that is behind the uniform is all the more impressive. Each of the people on the stage before you have personal and professional and familial experiences that have driven their approach to policy and in many ways underlie what becomes a source of policy for the entirety of the nation. So as we delve into the future of health, I don't think you could have a more open topic than that. I hope some of their personal stories also come through. And with that as a backdrop, perhaps I can turn to you first, Dr. Elders. I did a little research to think about the year of your birth and how the world has changed. And one of the things I noticed was that it was the height of the Great Depression. Yes. The average cost for a house was $5,000. A gallon of gasoline was 10 cents at the time. Could you take the floor and just give us a little bit of perspective and set a little bit of the context for our discussion today about what you have seen in public health? We would love to hear from you.
Women don't usually like for you to tell their age. But when you start out, but one of the things I know, I'm the oldest person on stage. I'm 90, and I'm proud to be 90. And I tell young people, especially students, those in medical school and starting out, I said I worked very hard when I was Surgeon General as a pediatrician, and it's coming along to make sure that we took good care of you, that we wanted to make sure y'all got immunized. I said, and then as you were maturing, I wanted to make sure you were all educated about your sex, so you would be sexually healthy. And I said now that I'm 90, I want you to take good care of me because I want to get to be 100. So I say all of that to say that since Dr. Theodore is wanting to make sure everybody knew that I was 90, and I'm proud to be 90. So, but medicine has changed so much. We've come a very long way, and you have to know that when you talk about coming from rural Arkansas, and the population of where I came from was 99, 98 when I'm up here. So it's really very rural. But we've changed. And people often ask, oh, Dr. Elders, did you always want to be a doctor? A doctor. The first doctor I ever saw was when I was a freshman in college. That was the very first doctor that now I didn't say that the public health surgeon didn't come out to give us immunizations. I remember we lined up like little ducks. So we all got our immunizations. We need to line up some more like little ducks, I think, to make sure that we all get some other immunizations. But we've changed a lot. Our immunizations are better. We've better because of Genentech. We got much better technology. And I'll have to give out. I told him I did some of the basic research on growth hormone so that we could treat. We didn't know we didn't have anything to treat them with. And so technology has made a great difference in how you will be able to treat and look forward to the future of public health, and many other things will change. And as I said, I was a pediatric endocrinologist, so I was very proud of the hormones that Genentech and the other companies were producing. But as I said, again, that was when I was treating patients one patient at a time. But when I became Surgeon General, heavens, you have to know, one of the things I was before I was Surgeon General, I was the Director of Health for the state of Arkansas. And I realized then I was responsible for the state of health of a whole state. And you know, I felt I was a top-notch pediatrician, pediatric endocrinologist, but I wasn't sure that I knew as much about taking care of a whole state. And I want you to know, first of all, learn early. You've got to listen to a lot of other people. You cannot do it alone. And just on Tuesday, we Surgeon Generals were in Washington, D.C., learning about and talking about healthy buildings. And when I walk into this building, obviously, you have a beautiful, healthy building. So and you get that impression from the outside to the lighting to the temperature, every seating, everything. So I've learned a lot. You have to learn a lot about lots of things, but the thing I learned the most is that my doctoring was not the most important. Many times, the things that's going on in that community, the things that's going on with the people working in that community, people like, sometimes you are learning, you have to depend on people like community health workers, all making a big difference. And so I just want you to know you're learning a lot, and don't feel I'm putting science down. I was a NIH Science, Career Development Awardee, so I was into science before, and I believe very strongly in science. But all of what we do is really built on that science, and it grows from that. And we're keeping on building. But we've not done as well in many of our community efforts. And I tell people all the time, our healthcare system would be an awful lot better. And I'm hearing that I was very impressed with some of the things you're doing here at Dartmouth, looking at things like mental health and knowing that that's really, I can't take good physical care of you if your mental care is not. So we have to really deal with the mental health care of all of our patients and the things that you're doing. And I was just really impressed with what they're doing on an undergraduate level. And the undergraduate students that I met was just really impressive. And I'm going to shut up because you've got lots of people. I always say I'm not going to say a word, and then I get it and I talk forever, and I'll butt in when I feel I have.
Perfect. And actually, there's a theme there that you drew attention to, and I'm going to throw the ball over to you, Jerome. And it's around the technological advances, and you've been a real leader in the social media space, in connecting. And it's hard to talk about communication without the issue of misinformation and disinformation, and how it is that you personally have tried to address that in the public health sphere, both when you were in office and subsequently. So I'd love you, if you could, to reflect on communication strategies in an era of advancing technologies.
You're going to give that one to me, huh? So you're right. It's been interesting. Well, first of all, I want to say thank you to everyone for coming. You all see that I wore my mask in, and this is not to say that everyone needs to or should be wearing a mask, but many of you all know my wife has stage 4 cancer, and we literally walked by the cancer ward to come into this room. Transmission is low here in New Hampshire at the moment, so that's in our favor, even though it's high across the country. I got vaccinated about 2 weeks ago. I was the first person in the state to get vaccinated, and it's important that we as clinicians continue to role model that type of behavior so that other people see it and it permeates. I got tested 3 times this week because I was at the United Nations, so I feel comfortable being in here with you. But I also want you to understand that one of the difficulties of being in our role is we're trying to give health advice to the entire country. And everybody has a different risk. Everyone has a different circumstance. Everyone has a different risk tolerance. And it's really hard from a communication standpoint to give advice that's appropriate for people in Boston, Massachusetts, at the same time you're trying to give advice to people in Boise, Idaho. And we saw that during the pandemic. We saw that New York was literally and truly imploding. I remember Tony Fauci and I looking at how Italy's health system was collapsing and saying, we have to warn the public. But then we go out and we give these broad recommendations, and most of the country didn't know anyone who'd had COVID yet. They say, you're lying to us, and you're shutting down our schools, and you're shutting down our businesses, and it's really impacting us in ways far beyond what we believe COVID will actually impact us. And that's one of the challenges that we had from a communication standpoint. But Dr. Elders said something, and I'm going to say it in a slightly different way because I like to think in quotes and sound bites because I'm younger, and you have to think in tweets. You have to think in, you have to talk to Sanjay Gupta, and when you're talking to Sanjay Gupta on CNN, you don't get this type of forum. You get 2 minutes to say what you want to say. And one of the quotes that I love that I would remind the young people of is that people need to know that you care before they care what you know. And if you take that with you throughout your career, it will serve you well. You need to create a connection with people. And folks who follow me on social media know I will engage with people. I will go back and forth with people. A lot of public health advocates push information out, and then they don't engage. Or when they do engage, it is in a negative way. I will engage with people positively. If people engage in a negative way, I will try to turn the conversation around. And it can be challenging. It's challenging when you've got 330 million people and you don't have time to reply to or engage with all of them. But I think it's critical that we recognize social media and the different ways people get their information. The young people, well, everyone in this room, surveys show that the majority of Americans get the majority of their health information online. Even I, as a doctor, I don't pull out my JAMA or my New England Journal of Medicine from the mail anymore and flip through it. I get my Twitter feed, and I see that Pierre tweeted an article out, and that directs me to then look at the highlights of that article that oftentimes have been curated by him, and I may not even read the whole article, but because I trust him, and I go, these are the highlights from the article, this is what it says. If we're not there in that space, then the Joe Rogans of the world are going to eat our lunch all day, every day. And I think it's important that we have a conversation about what responsible behavior looks like online in the future. We're talking about the future of medicine. But we can't afford not to be in that space, because that's where most people are getting their health information. And if we're not there, but other people with different agendas are, then we're going to continue to suffer.
It's a really important point.
You can follow me on Twitter and Instagram at Jerome Adams MD.
I think it's called X now. I just want to put that out there. Jerome, you brought up a very important point about the impact of COVID-19 broadly in public health, but there was a specific impact around the health workforce and driving many people to a point of burnout. And many of the challenges that many health workers have encountered were, I think, highlighted in the middle of the pandemic. I see many trainees in the room and obviously many academicians who are responsible for training. And Dr. Novello, maybe I can throw this over to you. You have thought a lot about the challenges on the workforce, both from a gender perspective, race and ethnicity perspective, a burnout perspective. I'd love to get your reflections about what we can do to reinforce the quality of our healthcare workforce.
Before I answer that, I want to just clarify one thing, that is that not all nationalities use technology. And when you're Latino, 54% of my health messages come from the television or the radio. And so that's very important. And if you want to change the behavior in the Latin community, just make it in a soap opera. So let's clarify that you touch everybody differently. So I just learned to answer my messages, because for the longest time there was always somebody there to do it. So I am very... For those of you who watched yesterday, it was a historic moment. It was the second time in 100 years that the 7 of us are together. And we did it in honor of the boss, Dr. Koop, the biggest man in public health in this nation, and I am so glad that Dartmouth is here to recognize it that way. So when I look at today what the healthcare worker is having during this time, it seems to me that who's going to help us? I feel we have a pandemic with an epidemic. And forgive me, the last time I covered my legs was in church, but these chairs are too low, and I'm not here to be Jennifer Lopez. So I am very worried about the way by which we doctors are getting a crisis within a crisis, and no one is paying attention. So when you look into the issue of 1 out of every 5 of us has a depression, 4 out of 10 has anxiety. And when you look into the fact that 63% have burnout and 69% when you're a woman, it seems to me that those things have to be addressed. But when they ask about burnout, they say, okay, I increase your salary. 58% increase in salary doesn't do a thing, for the simple reason that it's not money. What they're looking for is self-respect. So when you look into the woman, I am a little bit worried, because they have 69% basically of burnout, and they have 3 jobs. They work here, they work home, and they work 6 hours when they go home, because the society where they live give them all the time to do the electronic medical records when they go home and they have to take care of their children. So I look at them and I'm very proud of what they're doing, but the thing that is the biggest for women is the sexual harassment of their peers and their members' patients. So when they have 14% of them having somebody slap them in the butt, you have 60% of comments on their gender, how good do you look? And you are either a resident or a fellow that has not the power to turn around, slap them right where it hurts. It is very painful for us to stick around to something that hurts my ego, hurts my well-being, but I don't want to lose my job. It happens to the nurses at least more than it happens to the doctors, shoving, pushing, kicking, talking, and that they never report. They don't want to be whistleblowers. So 62% have this depression and overwork. And so that's why 100,000 of them left 2 years ago, and 610 of them are going to leave in 2027. When you look into this, we have a problem. And so when we have no knowledge that you know of my depression, they say, doctors, when you are depressed, ask your fellow doctor to give you a prescription, because society doesn't teach me equal as I teach my patient. They teach, take the conversation very, very far away from where you live. Make sure that a friend of yours, he gives you the prescription. Keep the paperwork very, very small. Don't ask your insurance to pay it. And more than anything, 41% of doctors and nurses keep it quiet. They never tell people that they really need. So when I look at a female that has her third job and in the 6th or the 10th year, she decides to go home to take care of her child and to take care of her home, 10,000 of them are waiting to come back after all that is done, and they have difficulty coming in. First and foremost, some of them have to repeat part of their board. Some of them have to repeat part of the whole career, and some of them come with a partial license. If that's the case, I cannot admit I cannot get paid. But what happens today, 37 states in this country have something that interferes with my licensing myself and making sure that I recertificate. And if that's the case, it says, have you ever had a mental illness? That disqualifies me of practicing, and 37 states still have that. So I have the stigma of my peer, of myself, and of my institution. So 41% of mine won't say it, because life as a doctor and as a nurse has taught me to be very, very, very strong. But when I think I have an illness, I feel like I have a stigma that doesn't let me move, so I keep it secret. So my productivity drops, my self-esteem drops, and more than anything, my guilt goes up. When that is the case, my empathy for the patient goes down, and my cynicism goes up. And when that happens, then I do not connect. And when do I not connect, then I say, am I in medicine for the right reasons? Am I helping the ones that I was supposed to be helping? So in that case, the productivity goes down, the hospital is not satisfied with me, and I am a person of problems, so I don't tell anything that is happening with me. I'm just having one of those days. So if you do not know what is ailing me, how can you tell me to help you in a moment in where we have so many people in this country? 29% of us are having depression, and only 41% of us look for some kind of a treatment, and the country has a 90% rate of depression. So in the presence of that, when no one sees me, because I don't have enough people to see me, so I drink or I have the use of drugs, and only 7% of those really even get to care. So there's going to be a shortage of psychiatrists, of social workers, and of psychologists, at least 31,000 of them by the year 2033. We are never planning for this. And what happened with graduate medical education? They just gave me, after 1998, 1,000 of those positions, of which 200 only would be for the areas in where people need it, and just for mental health. So somewhere along the way, 28,000 of us graduate, and there's only going to be 1,000 new spots for us to get an internship. So at this moment, I think this is going to perpetuate if we don't solve these issues. So the last thing I'm going to say is, women take better care than men of patients. There's no doubt in my mind. We are better than men taking care of patients. There's no doubt. We take longer, and for taking longer, they don't pay me enough. And I say, but the value-based care and the rating that you get in an institution comes from that woman giving you the best care possible. So I suggest, rather than, because most of them get a salary of $220,000, and at the end of 40 years we have a $2 million difference in the money I took home versus a man doctor. I would say, in institutions, find money from that value-based pot and gave them some kind of a bonus for having done what they have to do. And above all, stop the sexual harassment and make sure that you give them the 6 hours in what they have to fill their academic health records in here, not when they go home. It's extremely important if you want to keep them. Otherwise, you're just going to have bad medicine, because there's only going to be bad doctors practicing.
Thank you for that. Dr. Novello, you've spoken with great eloquence about some of the challenges to healthcare providers, and great force. And I think it's actually a nice segue to you, Dr. Benjamin. And I'm so impressed that after your time in office, that you decided to go from being Surgeon General of the United States to essentially working in a rural clinic again in Alabama, and at some level having frontline experience. And I would love to get your perspective on going from the position of Surgeon General to leading and founding a practice in Alabama and all the other activities, really focusing on preventive care.
Great. So I said yesterday, it's awful to have to follow Dr. Novello or Dr. Elders, and you did. So,
you're welcome.
So I'm just going to correct a couple of things. When you mentioned that many of us are population health is very important to me, but I define myself as a physician first. And so I didn't go back to being a clinician. When I was an intern, I attended the Medical Association of Georgia's annual meeting. And one of the intense issues was being discussed was that sexually transmitted diseases needed to be taught in medical school. I stood up in a room with maybe 10 or 12 people, and I said I'd never seen certain diseases except in a textbook, and I thought there was a need. The delegation, the Georgia delegation, forwarded my resolution, their resolution to the AMA, and they took me to the American Medical Association to speak to the same topic. The resolution passed, and I learned that one person can make a difference, whether it's in medical policy or in medical practice. And I learned I could make a difference in medical practice when the National Health Service Corps sent me to Bayou Battery, Alabama, the place of Forrest Gump. It's a pretty place, but it's a poor place. And I found a community of working poor, too poor to afford medical care, but too rich to qualify for Medicaid. I liked the people, I liked the community, and I wanted to practice medicine there. But I quickly learned that practicing medicine wasn't just sewing up the shark bites. I had to deal with the land sharks, the regulators, the reviewers, all the other things that come along with it. So I started this practice, and it's a town of 2,500. It's small, and for 22 years, I was the only doctor in the town in solo practice. But I still stayed involved with organized medicine. I believe you could get things done by working with people and communities. And we had Katrina, which taught me about disasters. I said 2,500 people, 2,000 lost their homes. So I learned how to do all the things, and you as a physician, people look up to you. And so you start being a leader and leader in that community. And I started doing things, but I still was doing community AMA and activities and joining every organization to get things done for the community. And so it was from there that I finally would, when I was asked to be Surgeon General, it was like, I can't leave my practice. But, but my patient says, it's okay, we can still call you, whatever. and they had done that anyway, because I was always on call. But it was because of having my conversation with them was that I wanted to have a voice at the table for them. This was during particularly time we were trying to get Obamacare passed and access to care. And so it was that reason of becoming Surgeon General and giving that voice, but also all the things that we do with population health. And I can talk to you about every thing. Prevention's my area, the National Prevention Strategy. My brother died of HIV. My mother died from smoking. She had lung cancer. And every, public health issue that's preventable. So I have these passions about all of those things. But as I mentioned yesterday, health doesn't occur in the doctor's office in the hospital alone. It occurs in where we live, where we learn, where we work, where we play, where we pray. Everything that we do. And the things that really change our health outcomes are the social determinants of health. The air we breathe, the water, the transportation, housing, education. Just by getting a high school diploma increases your life expectancy by 2.5 times. Simple things that we can make a difference for. So that's what I've been promoting, and when you get on someone like you said, like on CNN, they don't want to hear prevention. It's not sexy, but it's important. And it's important that we as clinicians remember that. The things I'm doing now is around the same things. Full disclosure, I'm on a number of corporate boards. I think you can change some things from the corporate boardroom, and you can change some things from the financing. One of the things is digital health. And it's like one of the boards I'm on is Doximity, and many of you probably use Doximity. Help physicians talk to each other to treat our patients better, make our lives a little easier, but also make the patients' lives. There are a number of companies out there who, particularly around mental health, where they can get on their phone and have that telemedicine visit, whereas they won't come in the office. We have to go where they are. So those are the type of things that I think we can do as we move forward. I can talk all day on everything, but remember, those of you who are clinicians, you're a doctor first, and people look up to you as leaders, and we have to lead. So,
Can I make a quick
Please.
point about Dr. Benjamin? So we all, we all are friends, even though we all served under very different administrations, different parties. And I think that's incredibly important, first of all, for people to understand that I've leaned on all of these folks. And I've leaned on probably no one more so than Dr. Benjamin, because she and I both were in the AMA together. She's closest to me in terms of age and in terms of the time that we served.
Thank you.
I know what I'm doing up here. I know what I'm doing. I've been married for 20 years, so. But I want to point out something that to me is incredibly important at this time for people to realize. The majority of black and brown people in the United States statistically live in what we call red states. And Dr. Elders is from Arkansas. We don't think of that as a liberal bastion. Dr. Benjamin, Alabama. We don't think of that as a liberal bastion. I worked under Mike Pence in Indiana as state health commissioner. And I'm concerned because you heard talk about the bimodal distribution yesterday, that we're shifting from and Dr. Moritsugu talked about this, that we're shifting from the regular bell curve to a bimodal curve. And what's happening is people are checking out. So there are so many people, including many of you all in this room, who asked me, how could you work for that administration? How could you work for those people? And I think it's important to understand that when you check out, if you're not at the table, you're going to find yourself on the menu. And Dr. Benjamin showed you that she found a way to help her people, even though she came from a state where you might not have expected her to associate with the individuals who were in charge at the time. I had to find my own way in Indiana to be able to advocate for health equity and the issues that I cared about. Dr. Elders had to find her way to be able to advocate, and Dr. Moritsugu and Dr. Novello find their ways to advocate, but you can't check out because you can't change the game from the sidelines. And I think too many of us are checking out of the game as we look forward to the future of medicine, and that's going to hurt the people who we most claim to be wanting to help if we aren't willing to show up and to speak out on behalf of the people that we care about in a very difficult time.
All I wanted to say.
And thank you, Dr. Benjamin, and to everyone else up here, because, again, you all have been great mentors to me and continue to be.
Just don't say she's your same age. Sorry.
I know.
I wanted to discuss one thing very shortly, and that is my biggest worry in whether we are in the bimodal or whatever is, why is it that in this United States since 2010, we still have 11 states that have not declared Medicaid for their populations, especially where 60% of the population that lives there is African American. So when you look into Florida and you look into Florida, Texas, and where the CDC is, 60% of the people in need do not have Medicaid. But you know what really irritates me more than anything? 60% of the people that live there are African American. There are 55 members of the African American caucus in Congress, and 20 of them are part of those people elected them, and they haven't done anything since 2010. Sometimes what you cannot get by anything that has to do by altruism, maybe we have to get it by guilt. And so the time has to come to put them to the podium. You want to stay in that post, you find Medicare, because it was just found for North Carolina by having your place where you did your internship, do it with the governor. So I get sick, and every time I see the mortality of children, the mortality of pregnant women, and they live in the same states in where most of the people who can make this better are advocating for something else and not advocating for the health of the people that put them in power.
Indiana was actually one of the first red states to accept the Affordable Care Act funding to expand Medicaid, and that was when I was health commissioner. And I don't say that to put credit on myself. I say it because there's a difference when you've got people at the table versus when you don't. And you talk about those different states. You need people at the table even if you don't agree with everything that's going on at the time. Indiana just increased their public health funding by 1,500%. There was a Politico article that came out about that at a time when all other states, especially red states, are cutting public health funding. And again, there are ways to work with parties even if you don't agree with everything that they're doing, or most of what they're doing, to advance the issues that you care about.
And I'm going to move us on to something else and just say that we have been dealing with politics all through our entire, not careers, but history. You know, Medicare was John F. Kennedy was stood on the floor, talked to an empty room about
Yep.
creating Medicare. There will always be political problems, but we have to stand up for what is right. We will get through them as long as we got good people to stand up for what is right, regardless of who's in charge of the politics or whatever. We have to do our part, particularly to take care of our patients.
You have to do your part, students and trainees.
So you
And as
asked
you
about
can
why
tell-
we
Yeah.
why we wear this uniform? Because when we wear this uniform and we ask for help, people listen. This is a Vice Admiral of the United States, and this means all that you have done in your life to be able to create public policy. So wear the uniform when you're doing your stuff, and make sure that they know that 3 stars moves the world.
Yeah. As you can tell, none of us up here is a little reticent from jumping in and giving our opinion. I'd like to just take a quick look at what the whole topic of this is, which is the future of public health. And I'd like to just start off by saying thank you all for the privilege of having us be able to interact with you. Because what I've said before is you allow us here to touch the future. Because you are the future of health. You are the future providers. You are the future citizens who are going to actually take what we have learned in our careers and put it into action. That's point one. Point two, I want to share with you very quickly something that we've all been saying, and that is, I want to share with you a comment that my pastor said to me once in a sermon. And he said, Ken, never forget, the good Lord gave us 2 ears and 1 mouth. And the reason for that is so we can listen twice as much as we speak. And I want to be able to say, this applies wherever we go. In the political realm, in the scientific realm, in your interaction one-on-one with patients. My God, I really wish that people in Congress would listen twice as much as they speak. Because if we were able to do that, we'd be able to communicate better. Similarly, when you are taking care of your patients or your communities, if you listen before you speak, more often than not, your patients, your clients, will provide you the answer and the direction to go in. It's very much like what Jerome said. You need to engage with your clients, with your patients, and not come down as sages on the stage, but rather listen and then react.
You said it better than I did. I'm going to steal that. See, I told you I love these folks up here.
So I'm going to take a little bit of a different approach in that I don't think, I mean, I do think, but you're the future of medicine, I mean, future of healthcare. I think you are healthcare, not the future, it's now. When I was in AMA, I started resident section. I was a resident, and I started students, but then a resident, so you can do things now. You don't have to wait to sometime in the future. As physicians, people look up to you. When I went to Viola Battery, the bayou is our major source of everything. The shrimp boats and stuff, the way they, the bayou is black. The way they change their oil, they let the oil in the bayou in the water, which is a little river, they let it in and put more in the boat. Well, I tried to get the state environmental folks to do things. Nobody would do it. It wasn't theirs. They said it was somebody else's jurisdiction and all of these things. So we just put barrels on the piers and asked them to put the oil in it. That's what they started doing, and it cleared up. You can do simple things. It doesn't take a lot of money, doesn't take a lot of planning and all that. You can show that leadership and do it. So it's just the idea that we can show leadership in everything we do. When you're standing in those meetings or you're in the hospital and you're going to be your advocate for that patient that can't speak up. You're going to be the person who does that. When you see something you don't agree with or you think is a great idea, speak up. You have authority. If you don't, just take it. Make your authority. You can see we're not very wallflowers here. But it's not a hard thing to do, and it's one of those things where when, we see things changing in the world, that change has to be us, and so that's why.
I also believe that we have 1 mile of knowledge and 1 inch of depth. We don't know everything. And we will find people that we never dreamed we would when we're Surgeon Generals. And we have to do things that we never dreamed we would know. I had to solve the issue of circumcision in the Hasidic community. It got to the point in where they knew the science, they just didn't know how to incorporate it in circumcision. But the issue that was really interesting is this, the New York is divided into the director of the Department of Health and the director of the Department of New York Health. And so he didn't believe it. They came to see me, so they would leave at 4 o'clock on Friday because it was the sunset, they couldn't. So it got to the point that I would say, do what I say or I will hold your hand, and you cannot touch a Hasidic. So they would just say, don't touch me, but I will do it. So you learn to work with things that you never dreamed. Circumcision in the male from a Puerto Rican woman. But at this moment, they knew the science, and we discussed the issue that you have to be able to do something. What happened? Some rabbi kissed a little kid in the penis with the circumcision, and the baby got herpes. New York didn't have a reportable herpes at all. This created a herpes representation, and now we haven't seen any one of those. But when they took what the state passed, they took it to the city, and the city said they were not going to obey it. And so they say, why are you not obeying it? Because a Jewish issue does not get solved by a Latin woman. And so now the law is the law. The Latin women dressed in pink passed the law, and the children over there, really, they haven't had a case of herpes because they promised, first, that if they ever were going to do a circumcision, that there will be the possibility of infection, they will go in an antiviral medication for life. And more than anything, they will gargle their mouths at least for 3 minutes, singing Havana Gila. That's the time it takes to be able to clean your mouth so then you can kiss the baby's penis. So many things change with things that you never dream you're going to work into, but it really advances the public health. So be ready for everything. At least I always say when I don't like the question, I talk Spanish, but in there they understood me, so.
It's fantastic. As we start to get a little bit close to a close here, I thought I might draw attention to a theme that you've all spoken to, which are many of the inequities and disparities that are seen in the current practice of both medicine and in public health. And I would love to get your perspectives at a high level as to what are some specific strategies that can be taken to address health disparities and inequity in healthcare systems. And Dr. Benjamin, I might say, as you mentioned, that the future in a sense is now, in a sense the future is here, it's just inequitably distributed. Yeah. What can we do to overcome that inequitable distribution? Maybe Dr. Adams, maybe I could turn to you first.
Well, so I was at the United Nations earlier this week, and I gave the keynote address at a digital health summit that the United Nations was holding. But the topic was digital health equity. It's a term that I've coined, and we're talking about the future of healthcare, or the future now. Big conversation with AI. And one of the points I made is that digital health has the capability to massively expand care, improve the quality of care, lower the cost of care, but it also has the potential to actually increase inequities. And one of the challenges that we have whenever innovation has come, and this is the dirty little secret about innovation in this country, is that in many ways, because of access and payment issues, we come up with great new innovations, but the people who most would benefit from them are the ones who are least likely to get them. So we actually saw, and we were talking about this, how breast cancer disparities actually widened after mammography became available. Why? Because affluent white women could go and get screened, and poor black and brown women could not go get screened because it wasn't initially paid for by insurance. We've seen that again, lung screening. There were algorithms that were biased towards black men, which caused them not to be able to access different treatments. I want to be brief here, but I do want to tell you all a quick story. When I was 8 years old, I almost died. And I almost died because I went into status asthmaticus. I've had asthma my entire life. And they had to medevac me from the small rural community that I lived in to Washington, D.C., to Children's Hospital to save my life. I think now about the promise of digital health. What if they'd had telemedicine available, or Project Echo back then, to be able to coach my doctors in my rural community through how to care for me instead of having to medevac me to Washington, D.C.? What if they'd had wearable devices that detected that my pulse ox was going down long before I actually showed up in the hospital? What if they'd had AI to be able to scour medical records and determine that people in my community were experiencing higher rates of asthma because of allergies or because of allergens from the tobacco fields that were in the area where we had worked? So many opportunities to leverage digital health. But again, we know that bias in doesn't just equal bias out. With digital health, with quantum computing, garbage in equals logarithmic garbage out, number one. Number two, you've got a digital divide. So what's the point of a wearable device that works on Wi-Fi if you live in a rural community where you don't have access to Wi-Fi, like my parents live in right now? There's a digital divide by geography. There's a digital divide by age. We know older people aren't as able to access as younger people. There's a digital divide by income. We know people who are more affluent can afford $200 and $300 and $400 Apple Watches, whereas people who aren't as economically advantaged can't. So I can get my AFib diagnosed where someone else might not be able to. We have to be really conscious, and the point I made at the United Nations earlier this week is we have to be intentional from the start. Because again, once the horse gets out of the gate, it's going to be really, really hard, if not difficult, to close that gate once again. And we don't want to see these great innovations in technologies actually increase inequities as opposed to realizing their potential to decrease inequities and bring everyone up.
I just want to say one thing, and is every moment that a technology comes out, I'm afraid I'm keeping more and more away of my patient, especially when he or she's poor. We are forgetting to talk, we're forgetting to touch, I'm forgetting their names, but I know exactly how to go and pull that button and I get everything technologically. But one thing that worries me is I see this importance of artificial intelligence, and that's driving me crazy. For the simple reason that artificial intelligence gets out the data that you put, and if your data is poor, it's going to be poor data added to poor data. But we minorities are not in the database, and therefore what you get out is basically not what is incumbent. So this GPT chat really basically gives you everything. You need an expert to judge it. It has no ethics. Artificial intelligence has no ethics. Artificial intelligence doesn't have the data of everyone. Wonderful tool for the future, but unless there is an expert that knows exactly how to judge what comes out, we might be in danger of really doing bad data for bad people. So my biggest worry is when 1 out of every 10 doctors will retire early because of the electronic medical records, where 32 doctors will never choose their profession ever again because of the way medicine is today. And basically when 54% will not let their children become doctors because they don't think it's the best thing to do, it seems to me that we're losing the thing in where my self-care of why did I study medicine. And if I keep seeing technology adding and forgetting about the patient and the touching and my name, I think it's going to be really, really hard to be able to connect. And for that, maybe robotic medicine is going to be the future, and we're going to be obsolete. So for that, everything good in technology is wonderful. Don't forget that so many people cannot access it. And for that reason, stay in the middle. Talk to your patient. Remember their name. And sometimes, like I would say that Joycelyn is from those places where they wouldn't pay us, but they will bring you fruits and chicken, and we will live with whatever they say. But in the street, the recognition of the doctor is as important or more important than having studied medicine. So don't forget, the patient wants you to know their name, and technology is keeping me more and more away from that moment.
You know,
Patients call me, give me shrimp, but they still give me shrimp. But the art and science of medicine, the science is very important, but there is an art, and we can't allow that art portion of medicine to be lost. No one's able to put a value on that, so they're ignored. And so it's up to us to make sure that we keep that art, meaning that, you know, that touch, that part, that interaction. That's the best part of medicine, is being a part of that patient one-on-one. There's nothing like it, you know, looking in a mom's face when you tell her baby's gonna be okay. I mean, there's nothing like that. We're fortunate. But I also think we have to embrace new things. We have to embrace technology. And we have to put those guardrails around it. And everything you said is very true. But it was like when you guys are probably too young, but they said that computers were going to put people out of business. They were going to put people out of jobs. Well, computers didn't. What's the biggest industry? Computers. So when we talk about things like AI or ChatGPT, it can make our lives easier. I heard something that was said, ChatGPT is not going to replace people. It's the people who use ChatGPT who's going to replace them. I use it for those pre-authorizations. I just put it in there and they give me all this stuff and I can go and cut and paste. It just cut out tons of time because it comes faster than I can read it. So you can use it as a tool. We do have to be very careful though that the information going in is correct, and we have to do all the things that you said. But we also have to be able to embrace those types of technologies and create them. You know, we've got people in this room who will be creating these new technologies. I mentioned I sit on these boards. I sit on the boards so that when we start to make decisions, particularly from investor side, if you're going to invest in a company, I want your company to make sure that this product is going to reach the people that I treat.
Yes.
And if they don't, you don't get our money. Believe me, they make sure. They also understand that in order to scale, which means get the most people, is how you get the most money. And you're not going to scale if you just stay in a certain little small group of certain financial status. So you're going to have to go everywhere. So it's not bad. It's not necessarily the worst thing, but we do have to be careful, like you
But I'm
said.
glad you know how to read it.
For the students in this room, always remember, that whatever community you go into, you're going to become a leader.
Yeah.
And if you're going into that community as a leader, the first thing, you've got, they feel you know medicine, You just I would think of the 5 C's of leadership. The first C of leadership, as far as I'm concerned, is you've got to be competent for what you're going to do. And that's you've got to have clarity of vision of what you want to accomplish in that community. Sometimes you go in and you have no idea of what that is. Clarity of vision. You've got to be competent to do your job. You've got to be sure of where you're going. You've got to be in control. And I think if you do not have those factors, if you do not have clarity of vision, you aren't competent, you aren't consistent, and do not have control, you aren't going to be able to really get the job done. And I think a lot in medicine. I think we end up in medicine. We're talking about me. I'm from rural Arkansas, but we're talking about we as physicians in many areas, we lost control of medicine. And I tell people all the time, we as doctors have been as competent and as effective as lawyers as getting things done, getting laws passed, as making sure that things are being done as they should be done. Because we sat down, we were taught, don't get involved in politics. That you as doctors, you're supposed to take care of the patient. You aren't supposed to be involved in the politics. But I think if we had been involved in politics, a lot of the mistakes that were made would not have been made. If we as doctors have been as educated and as involved in the politics sometimes of healthcare, and with healthcare, we have to know, we as doctors, we were busy taking care of the patient in front of us. But we weren't thinking about the building they're living in. Sometimes where they're living is the reason they're here to see us. I remember as an intern, I kept a patient in the hospital paying huge fees She had diabetes because they didn't have a refrigerator at the home to keep the insulin in.
Yeah.
We could have bought them a new house and two refrigerators. I'm saying that I feel that we as doctors have not been as in control of what should be going on in healthcare, and I think in the future, and I'm very pleased to see many of the things that's going on in healthcare and that is being taught, and you is learning more about, that you have to get out there and be in control. We can't sit back and say, well, I'm taking care of the patient, that's none of my business. If it's involved your community, you're the doctor, you're the leader, always remember you're not only competent as a doctor, you know the problem, but you also have to be committed to make it change and work to make sure that you the right people are in control. And I feel I won't say what.
You may hear people say, the future of medicine is bright. Don't accept it without slicing and dicing it and looking at it much more critically. The future of medicine, what is that to mean? Well, from one perspective, technology has really made great strides. Yes. 30 years ago, my younger daughter, who had type 1 diabetes, died. And in Berlin last year, I was addressing a group of technology specialists, and I said, if we knew then what we know now, she would be alive today. And technology and the way that technology continues to improve, yes, the future of medicine is bright. At the same time, as I think Regina mentioned, we have moved from the art and the science of medicine to the science and the business of medicine. And we begin to lose sight of the fact that medicine is a human profession. And we need to balance the high tech with the high touch. Given COVID, we've had this wonderful opportunity to test out telemedicine and telehealth. But as Jerome says, that does not reach everyone. And telehealth is a solution, but not the final and the overall solution. You've got to be able to mix the efficiency and the effectiveness of telehealth interventions with the high touch of the face-to-face communication with your patients. And so, making my point, be careful when you hear people say, medicine has got a great future. And you are going to be in charge of that future. So you need to take, as Dr. Elders said, you need to take control.
Okay, I just want to say one thing, and I want to put a perk for the primary care doctor. With the shortage that we have of psychiatrists, psychologists, and social workers, the primary care doctor is going to be the only one that will be able to follow up your symptomatology unless it's very, very, very bad and very acute, to be able to save you at that moment. And when I look at them, they're only 25% of the doctors today. And when I see you guys, you don't apply to primary care residency or to primary care doctoring. I consider them the detectives of medicine. They know everything. They know the review of system, and by the time they finish, they know more or less what you have, even when they don't Google you. So at this moment is the most proud moment of being a doctor, going back to the Marcus Welbys of the past, and they are diminishing by themselves because their pay is only $220,000 versus the $540 of the interventional cardiologists. So don't let money deter you of what you want to be when you grow up. Surgeon generals only make $127,000 salary. And we look where we are. We survive 1 year. So don't let the money run your career. Do the heart of being the doctor that you want for the benefit of humankind as especially that one that never dreamed that you will remember their name, that you will touch them, and you will kiss them, and you will care. So don't let medicine be just high technology. Don't forget the touch and the kiss. That's going to get you more satisfactions when you go to bed at night.
You know, I'm a family physician, so I have to agree with you in many ways. But I also want to say, go where your heart is, in addition to that. But just go where your heart is. I'm one of those folks who have an MBA, so I think the business of medicine is a reality, and it's really served me very well in helping me run a clinic where people don't have the money to pay to try to be able to keep it afloat and all the things and all the other stuff around healthcare. So the business of medicine is a reality that we have to deal with. I would also always tell medical students, but this is for nursing students, any other student, anybody, is prove yourself as a doctor first. If you can't be a clinician or whatever your area is first, you can't do any of this stuff. You won't have the credibility. If you don't pass organic chemistry here, if you don't get your boards passed, that's your job right now. Always prove yourself first so that you can come out and do all these other things. And so you're going to get a great education here, and that education will be your foundation that you can build on. But you got to get that foundation first.
Yeah, but the biggest practices are not with the most brilliant doctor. It's with the one that was not good, it was average, but care.
Care.
You know,
Nobody
we're
knows how
addressing
much you
a group of medical
know
students.
until they
Go ahead.
know how much you care.
That's right.
Yeah. We're
Patients don't
addressing-
know how much,
No,
patients
somebody
don't care how
cares
much you
how
know
much you know.
until you know how much they care.
Y'all notice I'm not saying a word.
Smart man. So actually, before you jump in, do we have a moment or so for questions from the audience? And I say that because generally speaking, we'd love to hear from you as well. So I'll leave open the floor
Particularly
for a
students
moment.
or trainees. Anyone is open, but I want to give the students and trainees a chance if you have a burning question to ask. Hey, you've got 5 surgeons general up here. So.
Please, there's a microphone, I think, coming.
Do I start? Okay. Hello. Thank you so much for coming here. It's such an honor. My name is Ariana, and I've had it on my notes. I'm a 4th-year medical student at Dartmouth, and I'm really proud to be saying I'm going into pediatrics. So I just want to start by saying I'm the daughter of 2 immigrants from Peru who are also pediatricians, and they were the 2 of them were half of the pediatricians in our small rural county in Northern California, and they served for 20 years, and they were the only Spanish-speaking physicians in that area too. So I guess what my concern is, yesterday you mentioned that the primary care physicians are the quarterbacks of our healthcare system. They're incredibly important, yet you mentioned the compensation. We have the lowest paid specialties, pediatrics at the bottom, then family medicine, internal medicine. And you feel that burnout because even in the healthcare system, it tells you that the value is less for the care that you give. And as a medical student with like $300,000 of loans, it's really hard to pick that specialty, even though I made that choice because of my parents. So what are you doing to support primary care physicians, and is there a change that's going to come? Is the gap going to close? How are you going to support us and prevent burnout?
There are places that will pay your career. Public Health, National Health Service Corps pays everything, gives you a rank and pays your books, pays your tuition. All you have to do is serve for the many years I pay for you. You pay in an area of need. That's one, without any doubt. If you don't want to pay it because all of a sudden you don't want to go where we send you, I charge you such an interest that you will never, ever. That's one. The other thing is there is a law that is trying to be passed by which the primary care physicians are leaving because they're tired of bargaining with the insurances regarding the payment system and more when it's managed care. So they're suggesting that maybe there should be something that says, I'll pay your loans. I pay your loans to be a primary care physician for X number of years, at least until we go back, get them from 25% of them into something as we only have 502,000.
Right.
Two
that's
quick
good.
things. Oh, go on, please,
Go
please.
ahead.
Well, 2 quick things I'd add to that. Number one, no one should be graduating from school anywhere with $300,000 in loans. Period, point blank. So to the Dartmouth leadership here, we need to do a better job of reining in the cost of education because it's a barrier to black and brown people, to immigrants, for even being able to go to a place like Dartmouth, or any institution, number one. And number two, on the back end, you shouldn't carry that around as a shackle the rest of your life, impacting your ability to make decisions for you or your community. So that's one thing we need to do, is rein in the cost of education. But number two, Dr. Benjamin talked about the business of medicine. And I agree, we can't let the business become the main driver, but it's an inescapable part. And one of the things, future of medicine, that will help answer the question that you bring up is really the shift from fee-for-service to value-based purchasing. And the reason why that will help is because then we will be able to direct the appropriate payments to the folks who are lowering the cost of care and driving up the quality of care, instead of directing the payments to the people who are able to generate the biggest fees. And so I actually do think, as we see that shift occurring and as we accelerate that shift, you'll see scope of practice issues go away, because the scope of practice issues are fights over who's going to get paid to do what service and whether or not they're going to get a fee for it. All of a sudden, if you have a program where you can bring in social workers and psychologists and community health workers to help lower your cost of care, and you just divvy it up however you want of the healthcare system, then that's actually going to pay the people who are lowering the cost and providing the care appropriately, and not put you in a situation where you feel like I'm doing all the work, but I'm getting the least amount of payment. So that's just two ideas. Many more ideas other folks will have, but those are two things that we are doing and we need to do to help address the issue you brought up.
Well, I think the education payment is a good one, but remember, African Americans work at least 6 years to finish a bachelor's degree because they work 20 hours a day, equal to Hispanics. And therefore, it's very important to realize that they graduate later, not because they're dumb, just because they take care of family and they take care of their own loan. But it's the ones that borrow more money to study medicine, while Hispanics borrow even less because they're afraid of the documentation. So you have to know the culture to be able to see what the university needs to do for them.
So as a family physician, I have to say I need some specialists to refer to. So those of you who are really passionate about your specialty, go into it. But
Patient with strength.
But some of the things I'm seeing right now that's happening is changing. Many of the primary care, it's just the numbers are down. They're going down. I'm on a board of a couple of large hospital systems, and can't find primary care. We're seeing the burnout and all the other things, but we're finding private equity is going after these primary care physicians, paying them a lot more to come and start their new companies, paying them the large salaries that 4 and 5 times what they could pay. And I spoke to a group of endocrinologists and doing a Q&A session. They were saying, well, it's hard for me not to take that when I got kids and family and all that. So you're seeing them leave the clinical services and going into this. What that does from a market standpoint is making our hospital systems and others raise the salaries and be competitive to bring those back. So we're starting to see it rise, just market forces paying primary care more, but it's slow. And this people coming out, students and stuff don't see it yet. But it's going to take some time.
Yeah, I'd like to just quickly address that, but turn that around, because you're talking right now about compensation and debt load. And I'd like to turn that around to say, what are we really talking about? We're really talking about improving access to the health system. And improving access definitely is predicated upon having more primary care physicians. However, it does take a village. And looking at some of the business models, there are other health professions that can help improve access, such as nurse practitioners, physician assistants, certified diabetes educators, which will help improve access. And I would suggest again that as you go through your training, you learn how to work best with those in the village.
So I'm on the board of Kaiser Permanente, and we have this integrated care system. We started medical school a couple of years ago. First students are going to graduate next year, teaching them that team approach, and so even here at Dartmouth, you're starting to get that team approach and understanding that integrative care model, and that also will help with some of the pressures and stresses on the primary care. And we can do it better as a team, and that team approach, you get better outcomes.
You had a question, you've been
this
popping
would-
up like a
yeah,
whack-a-mole.
Sorry, I didn't want to interrupt anyone.
Sorry.
Good morning. My name is Ella. I am a public health student here at Dartmouth, and I don't have a physician background, so I'm kind of taking a little bit different of an approach to this. But I am thinking about, Dr. Novello, you mentioned that there's a lot of burnout and that pay isn't really necessarily related to that. And so I'm just curious, we've talked a lot about primary care physicians and their importance. How do we address social determinants of health, food insecurity, housing, things like that, within the clinic with primary care physicians, while also not burning out those physicians and making sure that even though we have a shortage, we have enough time to spend with the patients, and that those physicians don't feel like, oh my God, it's just another thing that I have to do, as opposed to actually kind of caring about their patients and wanting to see those social determinants, improve.
I'm at Purdue University, and we have a project going on right now where we're partnering with our state medical association and our state hospital association in 211, which is a number that you can call to get referral to social services. And the idea is we don't want to overburden these primary care physicians, and we're leveraging technology. We're leveraging ChatGPT, we're leveraging AI to be able to say, okay, primary care physician, you type in what your patient needs, and it's going to generate a list, a customized list for your patients in terms of where they can go if they need food, where they can go if they need housing. And the idea is the more we do this, you'll eventually get to the point where the electronic medical record is doing this automatically for you based on input that you put in about the patient and about the surrounding community. And the primary care physician doesn't even have to do anything to make that referral happen. So it ties in a lot of the things we talked about up here today in terms of leveraging technology to lower workload for busy and limited workforce out there. So I just wanted to say that because we're literally trying to deal with that very specific issue right now.
Those are some of the important things that you need to know as doctors, and we talk about the future of medicine. Those are some of the things that are going on and coming along for the future. And I'm very pleased to hear about. I'm learning a lot about many of these because we didn't have all of the, back in my day, in rural Arkansas, when we had all of these needs and we had to take care of them individually. That will make medicine, you can spend more of your time really being the kind of doctor you went into medicine to be a real physician, to know that you could send your patients where they want to go, and there's somebody out there who's going to help you get all of those things done. And you've heard the word village mentioned, and I think that we all know that it takes a whole village and we as doctors, or maybe the leaders, the thing we didn't learn, nobody taught us to be leaders. We've got to learn to lead.
There's one public health issue that initiative that I'm a part of, I'm pretty excited to be a part of, that really, it's the Food is Medicine initiative. You know, the White House announced that, and then with the American Heart Association, we're basically a major player in that with the Rockefeller Foundation. The reason that's so important, we all know that the social determinants of health work, and getting people the right food, now we can write them a prescription. And the fact that we can write a prescription for medicine changes it. You know, when we passed the Affordable Care Act, we said insurance companies had to make 90% or more of their premiums had to go to clinical services to the patients, only 10% to administrative. Up until now, food was part of their administrative. And so they weren't going to pay for it because they would get dinged. So now it's part of the clinical part, and we can get these proper foods to people. And just something as simple as that, and that's public health, it's not, clinical medicine. I mean, it's important. But this Food is Medicine initiative is really, really strong. There's a lot of NIH funding. There's a lot of other funding that's coming along. So those of you who are doing that sort of thing, you might want to look into that.
Part of the problem we have is that we all think we know what is health disadvantages. and we still need education. There was a poll done in the United States where 47% of Americans believe there's no racism, and 17% they're still in the borderline. But when we look, somebody said to me one day, equity today, I said, you have no difference in your mind that equity and equality is not the same. So equity is you have what I can give you for the way that you live, I can offer you to make your life better. But you cannot have equity unless you do 7 things to get you going. And 2 of them is you have to take away the convenience stores, the food deserts and the food swamps that are in the minority communities, for which when they don't have fruit and vegetables that look so stupid, children are born with cognitive deficits. And if that's the case, when you hear every day you're black, you're stupid, you're dumb, your immunological system gets diminished, and that's why they develop diseases that kill them sooner and faster than the average American. We need education rather than preaching about health disadvantages and don't even know the statistics of what is it that we're trying to do to solve the problem. So public health is extremely important. And I can tell you because I hated it. I hated it. So you learn to love what you really can solve, and public health is one of those. Don't let anyone tell you that you're the least in medicine because you are into public health. So that's why I became a doctor in public health, to be able to take away the pain that I caused myself by hating it before. But, but you have to know what you're solving, and the health of food is crucial, and the stigma of being the different color. Martin Luther King, in his speech of the 2 countries, says one full of wealth and one full of poverty. And so for that reason, he says, morality cannot be pinching your face, but education can. And for that reason, you don't talk about what you do not know. I would say when it's public health, when it's health disadvantages, remember 47% believe that we don't have any racism in this country, and 17 are in the borderline. So food shortage is one, wealth is one, education is one, health is one, and this tunnel between education and jail also has to be taken care of if we're going to help the African American community. So education, learn it before we spoke it.
So listen, this has been an incredible conversation. I think we could clearly continue on for quite a long time. Please join me in thanking our guests and panelists today on this remarkable discussion. Thank you.
So before we leave, this is history. I want you to get out your cell phones, take a picture of the most studious surgeon generals I ever met.
And tag me on Twitter or Instagram.
And remember, this is rare. Very seldom will you have all of us together.
So I just want to thank you for accepting my calls, all of you. I appreciate that. And we're going to conclude, but just to the students, as Christina here, still here? Yeah. Christina is going to be having you, Dr. Adams. She's going to be, I wanted to have your books for the students.
Okay.
So she is the president of our Student Government Association.
Okay.
And so you'll be signing for them. And then also we want to leave you with a token of our appreciation. It's just humbling that you all accepted my call. Okay, but this is history, and I think Dartmouth and the Geisel and the DH community will never, ever forget this. So we want to leave you with, first, a copy of Dr. Koop's book, signed by Cora Koop. That will be coming to you. That will be coming to you. It's signed. But most importantly, my staff, the DICE team, which is the best team on campus, by the way. They're going to be presenting you. They should come up and present you with the special award or trophy that says this day, and then it also says the Koop Institute. So thank you, Dr. Bernstein. Thank you, Cora. And this is nice.
It's gorgeous.
It's gorgeous. Wow, it's beautiful.
Beautiful.
And that really will conclude today. But again, take your pictures.
That's pretty.
And thank you so much for your support. Thank you for the students for believing that this vision could actually happen, because it was for you. So have a wonderful day.
Thank you for having us.
Oh, nice.